Welcome to another episode of Ask the Expert. I am Amy Board, I am your host, and this month we are focusing on von Willebrand's disease. vWD is the most common bleeding disorder. It is said to affect 1% of our population, and yet there is so much that we don't know about vWD. My conversation today is with Dr. Christopher Ng from the University of Colorado Hemophilia and Thrombosis Center. And if there is one thing that I took away from my conversation with Dr. Ng, it is that this disorder, vWD, is extremely tricky, and it is not black and white, and continued awareness, continued advocacy, and continued patience is needed, I think, on both sides, patients, researchers, and physicians alike. I am so very excited that we are dedicating this entire episode to von Willebrand's disease, the research outlook, the treatment outlook, some of the psychosocial issues specifically around diagnosis and how difficult and frustrating diagnosis can be in the vWD space. I learned a lot today in my conversation with Dr. Ng. I hope you do as well. I can only imagine that this conversation in particular will spark further questions and conversations. If there was another takeaway that I had from my conversation today, it is that we need to talk more about this. And I can't wait for the 2020 Ask the Expert space, that we can get some more thought leaders and patient voices really about the vWD space more on the podcast. So I'm looking forward to that, and I hope that this will be a good episode for all of us to continue asking those questions. I was surprised by some things that I learned today in this conversation. Very much surprised. I was completely unaware that standardization in diagnosis is still not agreed upon in the physician community when it comes to vWD. If you get diagnosed in one facility, one state, that diagnosis could look different in another state with another physician. Standardization still needs to happen. That blew my mind. And it also enlightened me as to why there is so much confusion when it comes to vWD diagnosis and treatment. I will say that the importance of having an open and very authentic relationship with a provider, with a physician, with a hematologist is very important, I think, for both sides. And I know that is not the case 100% all of the time. And Dr. Ng spoke about that in really good ways. And I would just like to encourage listeners to not think that they are stuck in one provider relationship. The HTC space is a very unique space in that there is a comprehensive care team, and if you are having troubles being taken seriously by your hematologist, by a provider, by a nurse, I encourage you to attempt to have a conversation with another provider in that team, with a physical therapist, with a social worker. And perhaps you will be heard a little bit more. I will say that that is a loud, very loud request that I hear from the vWD space, and I really want to address that in some way. So we had some conversation about it today. I'm looking forward to hearing feedback from you guys and about digging into that particular arena a little bit more on the podcast in 2020. So I'm excited about today. I really am. I'm excited you're with us. I'm excited we're going to be able to get into it. Some housekeeping things. Since it is the holiday season, it is December. At least I hope you're listening to this in December. I would ask for you guys to subscribe. We always ask you to listen, but it would be awesome if you guys would subscribe to our podcasts on Bloodstream Media. Bloodstream, of course, is our flagship podcast with our host, Patrick James Lynch, and his wife, Natalie Lynch. And of course, Ask the Expert. We are dropping a new podcast coming up in the next few weeks. We are dropping Bloodstream Journeys, which is going to be a compilation of patient stories, community member stories, which is going to be a great listen. So make sure to check us out on any device, any platform that you listen to your podcast on, we'd absolutely love for you to subscribe and continue listening. I would love your thoughts and your questions, particularly around this issue. So I would love for you to reach out and let me know what you thought. That would be great. You can always find me at Twitter at Bordeaux87, or you can email me at mailbag@bloodstreammedia.com. I would love to know your thoughts. Today, our guest is Dr. Christopher Ng from the University of Colorado Hemophilia and Thrombosis Center. Dr. Ng is a pediatric hematologist, and he is a primary researcher for vWD. His passion is von Willebrand's disease, and his research study is with von Willebrand's disease. He does a lot of research in the lab there in Colorado, and so we are very excited to have him on the podcast. Dr. Ng would be more than willing to answer any questions through Bloodstream Media, so if you have some continued questions, please hit us up at mailbag@bloodstreammedia.com. So let's do this thing. Grab yourself a cup of coffee. Let's have ourselves a conversation. I am your host, Amy Board, and welcome to episode 34, or our vWD research update episode of the Ask the Expert podcast. Dr. Ng, thank you so much for joining us today. This is your first podcast experience, so welcome to Ask the Expert. I'm so excited to have you here with us today.
Yeah, no, thank you. Thanks for inviting me. I'm happy to be here and to talk a little bit and hopefully provide some information, some insight.
So share a little bit about your background and your current work at the Colorado HTC.
Yeah, so I am a pediatric hematologist oncologist. Right now I focus primarily in bleeding disorders, and I do, as you mentioned, work at the University of Colorado Hemophilia and Thrombosis Center. Most of my work is actually working with individuals with bleeding disorders, and more specifically with individuals with von Willebrand's disease, which is a disease that I'm particularly interested in. I have a relatively unique position, I think, in that I share both research aspects as well as seeing patients in clinic, and so I'm able to some degree bridge aspects of both boots to the ground clinical care, as well as trying to look at the next generation of things that we're trying to do in various different bleeding disorder spaces, and for more specifically in my case for von Willebrand's disease.
So Dr. Ng, can you give our listeners an overview of von Willebrand's disease? In particular, why is vWD so incredibly complicated and the diagnosis process so unpredictable?
It's a fantastic question, and this is, when I meet a new patient who potentially has von Willebrand's disease or has been referred to us for this, it's definitely a long conversation, and so I'll try to stick to the main points, but obviously we can delve deeper into any other aspect of it. So von Willebrand's disease is a bleeding disorder, as is probably most individuals who are listening to this podcast are aware, and it's a bleeding disorder that usually has symptoms of bleeding from what we call mucocutaneous areas, and those are going to be things like nosebleeds, bleeding from your mouth or your gums, in young women or women, that can be heavy periods. And the diagnosis of von Willebrand's disease is extremely tricky, and the reason why is because von Willebrand disease is based off of a deficiency of a particular coagulation factor in your blood that is aptly named von Willebrand factor. For those people who are familiar with hemophilia A, it's analogous to factor VIII in that case. In von Willebrand's disease, you have a deficiency of either the total amount or the function of that protein that's circulating in your blood. And those differences of whether you have a loss of the protein itself or the protein itself doesn't work that well give a lot of the nuances and a lot of the difficulties in von Willebrand disease. Because, again, in a contrast with hemophilia, instead of just looking at how much factor VIII you have or factor IX you have to look at both how much of the protein you have as well as how it functions, and in some cases, even how it's structured. And we have to use all of those data points together to really give us a good sense of how the diagnosis can be made, and then even in the context of making the diagnosis of the overarching von Willebrand's disease, there are different subtypes, and sometimes those subtypes are important for how patients may respond to medicines, or what medicines we should use for patients, or how we might expect people to bleed. And so it really becomes important that we kind of do a lot of specialized testing to really get at specific subtypes of von Willebrand's disease. So it can, at times, patients have definitely told me it feels kind of like a convoluted, extended process. You don't really get an answer of yes or no immediately, and it may take some time going back to the physician a few times, getting additional lab testing, specialized lab testing, to really get at what type of von Willebrand's disease you might have. The other aspect of it that definitely makes it tricky is that we, as a kind of community of patients, of providers who treat people with vWD, we haven't really well established a particular numerical cutoff for when someone fits a diagnosis of von Willebrand's disease. And this is probably one of the single biggest vexing issues to patients, and it's completely understandable. So one example I like to use is that if you, for example, had a von Willebrand factor level of 40 in your blood, in different centers in the country, in the United States, in different centers across Canada, the UK, other places, you may actually get a different diagnosis because the cutoffs are different in every place.
Really?
Yeah, so that you can see how that can lead to some uncertainty, right? So some people might say, well, in this place I was diagnosed with von Willebrand's disease, but now I'm coming here and you're telling me that I maybe don't have it, or my levels don't meet the criteria. And so fundamentally, I think that obviously instills a lot of uncertainty for individuals. And so, what I think we're trying to do as a bigger community is trying to minimize that confusion. And we are trying to do a better job of really standardizing this across, hopefully across the United States, as well as across even international communities, so that it doesn't seem as confusing, it doesn't seem so complicated, and that it does become a little more streamlined. But it really is a lot trickier than some other diseases, or some other bleeding disorders, for example, as I mentioned, compared to the hemophilia sphere, where things are a little more clear cut and a little more widely established. So putting that all together, it's completely understandable that vWD for a lot of patients is tricky. It's tricky for us at times, and that definitely makes it something that is difficult at times to study, but even for me, I think it makes it also exciting and interesting to learn more about and try to think about how we can do better at it.
That's incredible. I have not heard that that the levels are different. What is the process of standardizing something like that? Is that a MASAC issue with NHF? Is that a larger physician issue? How does that come to be?
Yeah, so I think that's a fantastic question, and I think all of those things that you talked about, I think play into it. I do know, as far as I'm aware, there's an international group that's really trying to come together, that's made up of many different representatives from all of these types of organizations, who are trying to really establish a kind of more firm cutoff line, or kind of international guidelines, if you will. Previously, I would say the most of us in the United States would have gone based off of some NHLBI guidelines, or National Heart, Lung, Blood Institute guidelines, created by the National Institute of Health. But those were relatively old guidelines now, established in 2008. And so I think the goal in the international community is really trying to come together amongst physicians, amongst researchers, amongst other maybe even non-healthcare providers, to really come together and try to establish more global guidelines. And I think that work is being done, and it obviously, we'd love it for it to already be done. But I am hopeful that in the next few years, we may see some of those outputs, and then have a better structure upon which we can, help people to both understand their disease, understand kind of where they are in the classification of things, and then hopefully make that less variable depending on where someone is diagnosed or where they're treated.
Dr. Ng, I'm going to go rogue already. We're like 10 minutes into this interview, and I'm going to go rogue and ask you a question that I didn't prep, but it's a personal question. You mentioned that you were drawn in particular to von Willebrand's disease, and you're so interested in it. And I know that from a patient perspective, it can be so frustrating and so disheartening within the diagnosis process. And I think at times I feel a lot of patients, a lot of women feel that they are embattled with their physicians over this. And so I just wanted from your experience, why were you so interested in this? What is the interest and what is the heart that you have for this community and this disorder?
Well, I think one of the things that definitely intrigues me, or definitely that I find very rewarding, is actually having conversations with patients, because it's not clear cut. And there's aspects of medicine that can be very algorithmic, and if A happens, then do B. And those are wonderful because those are usually driven by great data and great kind of experience that we have, and really good evidence to suggest that we should do A or should do B. Whereas I think, for example, in this disease in particular, it's much more nuanced, and I honestly appreciate and I enjoy talking to patients about the nuances, trying to get them to better understand kind of who they are, what their body is, in this case, what their von Willebrand factor is doing, and to really understand kind of their risks and what options we can offer people, what is kind of good option in situation A, but which might not be a good option in situation B. And I think empowering individuals with that knowledge of their diseases, what their diseases mean, and how to manage their diseases, I find very very rewarding. And so that's definitely an aspect of it that I appreciate. And then on the flip side, as I kind of alluded to in the very beginning, because it's a disease that still has a lot of uncertainty and is not as clear cut as maybe some of the other more well-known medical processes. On a researcher side, it's fascinating for me to be able to kind of switch gears a little bit and say, okay, this is an area that we don't know a lot of, and how can we contribute on a larger, kind of more abstract way of understanding more about von Willebrand factor, or maybe understand why certain people bleed more than other people. And so I think from many different levels, although it seems like a process that could be frustrating and at times absolutely is, I think the flip side of it is that there's a lot of opportunity there to learn more and to have good conversations with patients about it.
We opened this up to have listeners submit questions for this particular conversation, and some of our listeners have concerns that physicians and hematologists don't take women's bleeding issues seriously. And from your perspective, what is a best practice for patients to engage with their physicians about symptoms in order to be taken seriously?
Yeah, I think that's you're not the first person that I've heard that from, and I think it definitely requires a good relationship with your physician. Obviously, I would hope, and we all would hope that everyone is listened to, taken at face value, etc. But for those people who don't feel like they are being heard, I think there's a few things that you can easily do. Number one, you can obviously try to find another provider, and it may not necessarily have to mean some people feel like, well, I don't want to switch my doctor, or this is the only doctor I have. It can be other healthcare providers in that setting. It can be speaking with a nurse. It can be speaking with a physical therapist, with a social worker, with anyone kind of affiliated with that medical practice or with that care team, who may you may be able to open up a little more. They may understand you a little bit better. And then sometimes that information can come back to the medical practitioner, who may, hear it in a slightly different light in that way. I definitely encourage people to be, very open with any symptoms that they have, to really state that this is something that's bothering them. Because it may be something that it may just be an issue of communication, and someone else may not understand how bothersome or how concerning it is to the patient. So it's definitely tricky. I don't want to minimize that by any means. But I do think that looking for kind of alternative ways or alternative individuals to speak to may be helpful in kind of eventually getting across what you feel are some of the biggest issues that you're having to deal with.
I think that's excellent advice. And how lucky we are in the bleeding disorder community to have comprehensive care where there are other providers in that setting that, engage and talk to one another. That's really wonderful.
That's absolutely true. And, definitely, this is obviously going to be dependent on each individual practice and each individual center and how everything is set up. But, I would say there are many times, more times than I can even count, where, we see our patients in a comprehensive model and I see them as a member of a team, and someone who saw them before or saw them after will come back to me and say, this patient was really concerned about this symptom. And I know you talked about it, but they brought it up again with me. Is that something that you think you should go back in and talk about? And I say, yeah, obviously I didn't do a good enough job at that point to explain it to them or to make them feel comfortable with it. So I think people should feel very empowered to always discuss things. And if you don't feel like you got the right explanation or don't feel like you understand it well, to always speak up. And again, it should not, you don't feel like, shouldn't feel like you're confronting someone or feeling like you're, asking for more than you need. At the end of the day, as a patient, you should have a good understanding of your concerns and what may or may not be able to be done for them.
Switching to treatment options, and we had some questions from listeners specifically about hormone therapy. Before we kind of get into it, why is hormone therapy used in particular with women that have von Willebrand's disease?
So hormonal therapy, and usually this is brought up in the context of having heavy periods or sometimes what's called menorrhagia. And hormonal therapy has definitely been shown to be effective in controlling heavy bleeding. And this is even outside of individuals with von Willebrand's disease or outside of individuals with having bleeding disorders. These are kind of even individuals who are kind of normal, healthy individuals who have heavy periods. And so I think as an extension of that, using hormonal therapy is often one of the first line therapies that is used to try and control heavy periods. I do want to somewhat stress, however, that it really shouldn't be a kind of it's not as algorithmic, I guess, as it may sometimes seem, and that really it should be a discussion both with your hematologist and, if appropriate, your OBGYN about kind of what therapies might be best to start initially, what's going to be your second line therapy, kind of your patient specific algorithm of how you may decide to treat any particular symptom, in this case, heavy periods or menorrhagia.
So Dr. Ng, when it comes to hormone therapy, having that be the first line of treatment, what would be the cause for a physician to kind of move away from hormones and actually treat a young woman with hemophilia or with von Willebrand's disease like their male mild hemophilia counterparts and use clotting factor rather than hormones?
Yeah, so that's a fantastic question. I think usually in conjunction, and I can kind of speak to maybe our local practice, and this kind of give you a sense of at least how myself and maybe some of my colleagues here at the University of Colorado also approach this. So we do see patients at a combined, what we call our women's bleeding disorders clinic, but really it's a combined clinic with both an OBGYN as well as with a hematologist. And I think that fundamentally allows for a lot of information sharing, a lot of expertise sharing about, an experience of, this situation may call for using a clotting factor, using a kind of a hematology drug. In this case, it might be a situation where you would use more of a hormonal hormone treatment. I can think of, definitely situations, and what usually comes up is for individuals who just, quite frankly, don't want to be on hormonal therapy, which is perfectly appropriate. Maybe it causes them side effects, or they just fundamentally don't like that idea. And using a alternative such as a clotting factor, other medications we'll use are antifibrinolytic medications. All of those can be very efficacious in treating heavy periods in women with von Willebrand's disease. And I think again that's where it's really important to hopefully have a good relationship with your provider and being able to express why you think it may or may not be a good option for each individual patient. That could be something of just preference, or it could be a medical reason to not use estrogen or not to use progesterone or any other hormone in a particular individual. And really, I want to stress that I think it, especially and many of the large centers across the country now, this is really becoming a multidisciplinary approach between adolescent medicine, OBGYN practitioners, as well as the hematologists. And through the combination of all their expertise, it really, again, should be a little bit less algorithmic and a little bit more of here are some standard approaches and here are some other approaches that we can use in your case if the standard approach doesn't fit you well.
Is there any research being done on the effects of hormones if you start at a young age? Is there anything being done with that?
I honestly, Amy, I'm not. I can't honestly say that I'm super familiar with that sphere itself. I will say that we have a pretty across all of medicine. We have a very long history of using hormonal therapy for various different things, from contraception all the way in older adults to older women, usually using it for hormonal replacement therapy. And there clearly are some side effects that should always be thought about and discussed. But in general, I think across the board, we think of them as quite safe for use for long term. I mean, there are many women who are on it for many, many years. And so specifically in the bleeding disorders space, I think it's an area that very clearly we could do more research on, could understand a little bit better. Is there any specific differences for our individuals with von Willebrand's disease or hemophilia or et cetera, et cetera?
So, Dr. Ng, I have a friend in the space that was diagnosed as having von Willebrand's when she was a teenager, and in her, I guess, mid-20s, she was, I'm not exactly sure what the process was, but they started to move away from that train of thought that maybe she had a platelet disorder or a platelet dysfunction. And I know that's starting to become a little bit a part of the conversation. Can you help us? What is the difference between vWD and platelet disorders, and why is it so nuanced when it comes to diagnosis?
Yeah, fantastic question, and one that even the confusion I think amongst the individuals and the general population is perfectly appropriate, because even sometimes for us it can be confusing. I do think that the number one reason why it is confusing is because they look so similar from a symptom standpoint. So individuals with a platelet disorder have very classically similar bleeding, what we call phenotypes, or similar bleeding symptoms as an individual with von Willebrand's disease. So those are going to be things, again, like nosebleeds, easy bruising, heavy periods, etc. And so kind of on face value, when I for example, meet a patient, it's hard for me to tell, okay, are you more likely to have a platelet disorder? Are you more likely to have von Willebrand's disease? And then as we go through the process of it, we start to kind of tease them apart. Now, the reason why they often look so similar is because actually von Willebrand's disease and platelets work together. They're kind of the left hand and the right hand of making a strong initial blood clot. And so you actually need both. Von Willebrand factor has a receptor on it that actually grabs onto platelets that are floating around in the blood. And it really starts the formation of what we call primary hemostasis, which is a big word, but it's basically just, starting a blood clot to be formed. And so you can see that if you don't have enough von Willebrand factor, you can't do that. Or if your platelets don't work, you also can't do that. And they have to work together as a team to really start that process in a very robust fashion. And so if you don't have that, it looks very similar, and that's why they are often hard to tell apart, and that's why they can often get confused for each other. And so on a testing perspective, what we really try to do is we try to do our best to run special tests to basically eliminate one half of those. So I think very classically, you may have someone who, as your friend was initially diagnosed with von Willebrand's disease, and maybe had got all the testing on the von Willebrand's disease, but really hadn't gotten tested on the platelet disorder side. I do think that a lot of individuals now are trying to test for both kind of upfront to kind of see what path an individual may find themselves. But that's not always the case, and there are definitely patients who have received a diagnosis of one in the past who may actually have the other. And so I think one aspect that's important for patients who feel like they may be misdiagnosed or are concerned about how they're responding is really are the therapies that you are getting or the treatments that you're getting effective? And if they're not, then that's definitely a time where you may want to have a good conversation with your healthcare provider about, should we be retested or has anyone considered an alternative diagnosis? But to kind of come back to the initial question, it is very tricky to tell the difference between the two just on the symptoms that people report, and requires a lot of specialized lab testing to kind of sometimes tease those two different things apart.
Clinically, what is the approximate time period for a menstrual cycle, and when should patients see a physician? Basically, when should physicians take their patients with menorrhagia seriously? I mean, what are you guys looking for in terms of days and the amount of bleeding?
Yeah, it's a great question. Actually, it actually was a good refresher for me to actually go back and see exactly what some of the most latest recommendations or latest kind of consensus is on it. And so actually it was really helpful because I went back and looked at some of the most recent what we call our ACOG guidelines, which are the American College of Obstetricians and Gynecologists. So this is the group of OBGYNs who get together and kind of set some of the national standards of this. And in some of their latest guideline data, they suggest that the average time of menses should be about 5 days, which I think for many individuals is kind of what they might expect a period to last for. But it should be very clear that can vary, and it can vary for so many different reasons. Some of them, kind of more truly pathologic, like having a bleeding disorder, as other times is just having some normal variation. I think anytime symptoms are, I would say, lasting kind of longer than that, especially if you're getting into like a week or so of having a period that's definitely different for you, that's certainly a time that you should think about seeking medical attention or, bringing it up to your physician, calling into the nursing line, anything like that. Because I think once you start to get out of that time frame, we start the likelihood of something kind of more what we call pathologic, or the likelihood of something else causing it, I think increases. And so that's really when you want to kind of be on alert for that. And then obviously anytime you have symptoms, feeling lightheaded, dizzy, etc., those are going to be situations where you're going to want to seek medical attention even quicker, because you may be passing so much blood that it could be making you anemic, making you feel not well. It is hard, though. I will say this, and it's definitely a question that we get a lot about kind of, when is too long, when is too much. One of the things that we often will say to patients over the phone is that, we try to do with our patients over the phone is to, not say that at any one point this is, this is the definitive answer, but to say, look, this sounds okay now. Let's check in again tomorrow. And if things are better or worse, then that'll change our opinion. And I encourage people to really, again, hopefully they have a good relationship with their team, with their providers, where they can do that. They can, call in every day. They can update people on how your symptoms are. It's gotten worse or better. And I think that often helps us kind of make that decision. But it's tricky. There's no question about it. It's really tricky to think. It's hard to make a kind of strict cutoff line there.
Moving more into the treatment and maybe, potential future treatments, what is being used currently to treat von Willebrand's disease in particular? We talked a little bit about hormone therapy, but kind of take me through what is being used currently.
Yeah, so I think, in terms of, current treatment options, there's a broad range of things that we currently use for von Willebrand's disease. And I usually, when I talk to patients about this, I kind of start on the kind of small side and then in a way kind of work our way up. So some of them are basic things are things like antifibrinolytic medications. Those have the trade names of usually Amicar or Lyseta. And those medicines help to prevent blood clots from being broken down. And so they're really good medicines for sometimes what we think of as a little bit maybe more minor bleeding, things like nosebleeds, sometimes for heavy periods, gum bleeding, etc. And then on the other spectrum of things, we have clotting factors, which I think some individuals are familiar with and many people at least have heard about. And those situations are where you basically replace the von Willebrand factor that is either not present or not working in someone's bloodstream. And those are going to be IV infusions, and there's many different types of clotting factors that are available. But fundamentally, they all do the same thing, and they try to increase your von Willebrand factor level in your bloodstream. The advantage of that is that they do them rather quickly because it's an IV infusion. It's very rapid. It's within minutes. Your levels are normal. The downside is that it's an IV infusion, so it's not something that you can do at home. It's not a pill that you can take at home. So there's definitely some drawbacks to using those types of medications, but there's often a fair number of people who use them or keep them at home. Some people use them only in emergency situations. There are other people who use them on a more routine basis. And then the other medicine that kind of, what I say sometimes fits in the middle of it is a medicine that's called DDAVP. And DDAVP is actually it's a hormone that your body naturally produces, but you just take it in higher quantities when you use it as a medicine like this. And it actually releases von Willebrand factor into your bloodstream from your what I call your endothelial cells, or the cells that line all of your blood vessels, because that's actually where the majority of your von Willebrand factor is made. And so the benefit of DDAVP is it can be given either intranasally, it can be given IV as well, and it causes a rapid increase in your von Willebrand factor levels, and it's really good, for kind of something you need von Willebrand factor for maybe a day or so. Something that you don't need an immediate response. For example, you have a nosebleed, it's gotten a little bit better, but it's continuing to bleed, and maybe you want to kind of make sure it doesn't bleed over the next day or so. The downside to that medicine is that sometimes it can lose its efficacy over time. You can't use it many days in a row, and so it's sometimes tricky to use. And so, putting them all together, those are really kind of the armamentarium I think we still have for von Willebrand disease at this time point. We unfortunately don't have any of the newest and maybe the coolest drugs that some people think about when they think of hemophilia and some of these other things. But I do think that armamentarium still provides patients with a lot of good treatment options, and there are situations where one might be better than another. And so I think it's important to clearly define with your healthcare provider, okay, in this situation, this might be a good time to use this. In this situation, it might be a good time to use this, because there are definitely different clinical times where one might be more effective or one might be something we wouldn't want to use, etc.
So now we get to the fun part where we all can be nerdy. I'm sorry, listeners, to have this part of the conversation so late in the game, but what is the current outlook? Where is the research going towards? I have a Google alert set for von Willebrand's disease, and just week after week, it financially it just says that the von Willebrand space is just going to be booming in the next decade. And so what is happening? It's a loaded question, but just from your vantage point, what are you most excited about, and what's the outlook for treatment for von Willebrand's disease?
Yeah, so I think there's kind of there's a twofold approach that I often kind of think about when I think of von Willebrand disease, and it kind of breaks down into this kind of more lab-based approach and then more kind of clinic approach or more clinical approach. And I'll start with the clinical approach because it's probably the one that's going to be kind of the more it's one that's probably people are going to see more quickly. And I think on that aspect, it's really trying to understand better who is going to have bleeding complications, because even, for example, someone may have the same level of von Willebrand factor as somebody else, another individual, and yet they can have completely different bleeding phenotypes or different bleeding symptoms and different bleeding severities. And really at the heart of the matter is trying to understand that better, is trying to understand on a biological level why patient A bleeds more than patient B. And what we're doing now is we're looking beyond just what is your level of your protein, or even what is your function of your protein, which is kind of even a second level approach. And we're trying to look at things like what are the other genes that you have in your body that may affect bleeding or may not affect bleeding. Can we use things like genetic testing? Can we use things like big genomic experiments to understand on a very population level, individuals who have von Willebrand disease and have this other mutation in some completely independent gene are more likely to have bleeding. And I think that's going to be, for a lot of people, the biggest thing that they're going to see. In a way, one of the things that we often use, one of the terms we often try to use is modifiers of bleeding. And that's what really we're trying to identify now, is what are the significant modifiers that is going to cause someone who has a level of 35 to be more on the bleeding side or less on the bleeding side. And then hopefully we can understand that and then provide that information to our patients. And that's being done on many different levels, not just in terms of genes, but also in kind of how von Willebrand factor is cleared from your body, where von Willebrand factor is stored in your body. So people have all kinds of different hypotheses or different ideas on how all these things can modify the eventual bleeding phenotype that people have. And so there's a lot of us who are kind of focused on that aspect of it, in the sense of like trying to better understand what is causing the bleeding. Because if we don't understand what's causing it, it's almost too far to think about how you can make that better, how you can change that. And then, on the kind of the other side, which I think is what more people think of in terms of, kind of more classic drug development. Unfortunately, I do think von Willebrand disease hasn't gotten the same degree of emphasis as, for example, hemophilia has, in terms of, gene therapy and all these other novel products. As far as I am aware, I don't think I can think of any kind of real obvious kind of next steps in kind of those big contexts. But what I would caution people, or what I try to be optimistic about, is that this is in a way where hemophilia was maybe 10 or 15 years ago, and it really took that concerted effort of research and understanding more about what was going on in hemophilia bleeding and how we might then affect it. And I think a lot of that is going to spill over into von Willebrand disease. Exactly how, I don't know. There are some of the medications, for example, that are being likely developed for hemophilia that might work in von Willebrand disease. And I think in the next 5 to 10 years, we may see some of that spillover effect. It's kind of hard to tell exactly what that might be. But I think it's, the emphasis on understanding coagulation, on understanding how we can maybe alter coagulation, in the end is a net positive for everybody in the bleeding disorders field. And I think is going to have some good output for individuals with von Willebrand disease.
So just to clarify, what you're saying in particular with von Willebrand disease is that it's not as black and white as hemophilia in terms of the level. So if you have 35% of von Willebrand disease, you could bleed more, you could bleed less. And so it truly is individualized in terms of your own body makeup, and you guys are trying to figure that out of what are some other factors that could cause that or cause more bleeding or less bleeding.
That's absolutely true. And that's why, in the hemophilia space, I think there's been a lot of emphasis on just to, kind of acknowledge the gorilla is gene therapy, right? It's all designed in hemophilia to raise your factor VIII levels. And certainly raising your von Willebrand factor levels is a good thing, but it may not be the sole reason why people bleed. And so understanding on a more fundamental level of why we see variations in bleeding, I think is really going to give us that next target of, okay, this is why maybe, 40% of von Willebrand disease patients are more likely to bleed. So we need to design a therapy for that. And this might be 20%. It may be a completely different reason why these other 20% of people bleed. And look, we have to design a therapy for that. And I think right now in the research sphere, we're still trying to find that out. And we're still trying to define them. There's a lot of great people, not only in the United States, but across the world who are really putting a lot of emphasis into this type of research and really trying to identify the kind of core biological reasons of why patients have these problems. And that's going to give us kind of a more narrow approach of, okay, now that we know what the problem is, now let's take the next step of how we're going to fix it. So that I can't quite see yet. I can't tell someone, this is going to be the next big thing in the next 2 years. But we're clearly on that track of trying to understand on a very fundamental scientific level what's wrong, and then decide and then figure out how we can make that better.
Dr. Ng, are there any active clinical trials for vWD treatment going on currently?
Not that I'm aware of, Amy. I'll be honest with you. I don't always know. I'm not always, the kind of. I don't always hear about the latest thing as soon as they open. Obviously, I think there are definitely some clinical trials associated with some of the clotting factor concentrates and using them, for example, in different disease phenotypes or different types of populations. And so I would say yes, there are. They are perhaps more, you could argue, a little bit more variations of what we kind of already might know or might already predict. I would say that they are, especially at the larger centers across the country, many individuals are very up to speed on kind of different clinical trials that are open. And so I would definitely encourage people to, talk with their local centers. And in fact, there are sometimes very center-specific clinical trials that are open, and they may not get a lot of national publicity, but for any individual at that center, it might be very beneficial. And so, we at our center try to always educate patients and really give them the latest update on both kind of what's being done on a kind of big picture clinical trial scale, as well as, here's something that one of our physicians or one of our individuals here thought might be a good intervention. Are you willing to take part in that study? So I think there's always something new, and I would encourage people to always kind of be on the lookout for it and have that conversation of, is this something that's going to be helpful for me? In either understanding my disease better, being treated for my disease better, etc.
Dr. Inge, I'm going to go rogue again. My apologies. But just to give some context for our listeners, what are you currently working on in the lab? What are the questions that you're trying to answer? In particular, what is something that you're very interested in when it comes to lab work with von Willebrand's disease?
Yeah, no, that's great. I always love to talk about some of the work that we do here in our lab and in our center. And I think fundamentally, I'm kind of, as I mentioned in kind of the overview, I'm one of those individuals that's fundamentally very interested in trying to figure out why individuals bleed and why this individual might bleed more than that person. And so, a lot of the work that's going on in my lab is looking at things like large genomic analyses and understanding, how genes or proteins that are far, far away from von Willebrand disease, and something that we may never have thought that, this protein would be involved in bleeding, how that might actually affect bleeding. And we do that through various different ways. We do that through kind of computerized models. We kind of build models of bleeding and try to understand, okay, if we turn this one up or down, how does that affect the actual function of bleeding in the end? We also do it kind of in, very traditional laboratory experiments and thinking like, okay, if we make this gene express more or express less in a cell, how does that affect von Willebrand factor function? And so, we try to look at it in all of those contexts, and we're really trying to identify, really those candidates, those things that are going to be maybe the next big breakthrough of understanding why patients may bleed. And we have, at our center, and this is true across many different areas, we have such generous patients who are willing to enroll in our clinical trials, to donate blood, to allow us to analyze their genes and to better understand why they may or may not be bleeding. And they do that with the knowledge of this is hopefully going to advance the field in the next 5, 10, 15 years and really kind of, maybe in their lifetime see the output of some of the work that we're able to do.
We have a listener whose son has both severe hemophilia A and von Willebrand's type 1. And his mother feels that he is forgotten a little bit in this community since it's normally one or the other. And she wonders if there are any future therapies for him in particular. Yeah,
I saw that on the questions that you had sent over, and I can definitely empathize with this mom, because I do feel like as maybe sometimes, and this is something we should not do as much, but sometimes we kind of put people in just clinical categories. And this mom is right. Usually people fit into one or the other. I don't know if I can't honestly, and I don't want to be pessimistic, but I can't think of anything right now that will kind of meld the two together. But I do think one of the significant advantages or one of the hopeful things for this patient is that they kind of build on each other. And so, this patient has kind of two significant bleeding disorders. And if we can make one of them a little bit better, that's obviously going to make the overall bleeding phenotype better. And so my hope is it's kind of almost like a back and forth approach. And as treatments or medications or therapies for hemophilia get better, then that's going to, really hopefully kind of quote unquote take care of that as much as possible. And then as von Willebrand's disease gets better, that'll help. And so in a way, my hope for this patient would be that this patient would kind of almost get the best of both worlds, and that their underlying bleeding phenotype or their underlying symptoms, which ultimately to this patient is probably the thing that bothers them the most, is going to be ameliorated by both aspects. And so I think there's definitely some optimism here, despite the fact that I can completely understand how it kind of feels like you're in neither camp, and that kind of makes you feel like you're kind of left out.
We have another listener story, specifically about diagnosis. A mother again writes in that her children, they have been diagnosed with von Willebrand's disease, and she says she knows she has it as well. But every time she drives to the treatment center, which is hours away, her stress level is so high that her levels appear normal. And she was, wondering, does stress have something to do with the diagnosis? What are the mechanics of that? Why is that happening during diagnosis? I've heard that as well, that you can come in with levels and 2 weeks later you can come back and they're normal. Tell us a little bit about the diagnosis process.
Yeah, I kind of, honestly, Amy, I didn't address this in the initial beginning part. We talked about how difficult it is to make the diagnosis of von Willebrand's disease, just to make it a little more, just to make that a little more straightforward. But this is another layer that just makes it so much trickier. And so it really relies on the fact that von Willebrand factor is something that we call an acute phase reactant. That's the medical term that we often like to use. But in the end, all it means is that it can change depending on how a patient is feeling or what a patient, how ill or not ill a patient is at the time. So things like stress, very clearly things like heavy exercise, having the flu, being what we call inflamed, causes your von Willebrand factor levels to rise. And that can absolutely make diagnosis tricky, because you can see someone who might be, a little bit on the borderline. They may not be a very severe deficient patient, who, just as this individual has said, they're driving in, it's hours away, it's a stressful drive, etc. They come in, they get their blood test, and their levels are normal, at least by the numerical levels of the blood drawn at that time. And this is absolutely tricky, and this is happens unfortunately more often than we'd like it to. I think there are a few strategies that you can try to do to get around some of these conundrums. Number one is people should be tested multiple times usually, especially if you're on that borderline, because we don't know if you are high today because you have a cold or are you truly normal. And so usually what this means is individuals who kind of are on the borderline do unfortunately have to get tested a few times to really get a good sense of what their baseline levels are. The other option, and something that we try to do in our center because we see patients from a huge geographical area, is to do our best to work with primary care doctors, local hospitals, local laboratories, where these individuals might be able to, not even just be seen in a center, but just to go get blood drawn and have the labs faxed over. That might be something that's, simple enough to have done in terms of, getting a sample that's a little more true or a little more of a baseline, if you will. And then kind of on the maybe a little bit more on the other extreme of testing, for example, in this case, for this individual who may already have a child who has von Willebrand's disease, so kind of another known individual, if and when that child has a known potential genetic mutation for von Willebrand's disease, it's also sometimes reasonable to sequence the mother or other members of the family if the diagnosis still is kind of in question. Sometimes that can provide some certainty, or at least another good clue. So that's something that I think, in this day and age, with the cost of genetic testing becoming so much cheaper, is in honesty more of a reality. It's not indicated, I want to be very clear, it's not indicated across the board. It's not something everybody should get. But in certain situations, for example, like this, it may, help to resolve this question that this family is dealing with, and not have and mean that they don't have to keep driving back and forth so many different times. But it's absolutely tricky. There's no question about it. And we see this also sometimes with very mild hemophilia A patients. They can rise just like this as well. Factor VIII is sometimes also acute phase reactant.
That's interesting. I have not heard that mild hemophilia patients are like this as well. That's interesting.
Yeah, so von Willebrand disease, I would say, is probably, I think we both think of them as acute phase reactants. And so for whatever reason, I think it's probably because von Willebrand disease levels are a little bit higher in general, that it becomes more of an issue because you're kind of closer to the normal level. But certainly, these types of situations may or may not occur in mild hemophilia as well.
Dr. Ng, to wrap us up, as a researcher and as someone who is committed to this community, what is giving you hope these days in terms of the landscape of vWD diagnosis and treatment?
Oh, that's a great question. I mean, I think I'm always optimistic. I think just because I love the disease and I love thinking about it and researching it and taking care of patients who have it. But I think from a bigger picture, some of the things that give me hope are really an increased awareness of it. And I hear this, at least I hear it a lot from patients about, maybe, they didn't know about this disease, and, it's very often very classic as being primarily a pediatric hematologist. I often see I often see pediatric patients, and then I kind of find other members who may have that disease in other parts of the family, and for them it's kind of a wow, I didn't realize that I had it or that I might have it. So I think that increased awareness is awesome, and I think it's happening on both a level of just patients knowing it. I think with the advent of the internet and increased communication, that's really just kind of being out there. And then I also think on kind of a more organizational level, some of the larger bleeding disorder and even non-bleeding disorder communities are really trying to focus a little bit more on von Willebrand disease and other types of bleeding disorders. And I think bringing all that emphasis together, understanding on a very clinical level of making sure that everyone gets seen and everybody gets appropriately diagnosed and treated. And then kind of on the other end of the spectrum, putting more emphasis into understanding it better from a research perspective. I mean, I think it's a really good time to be in the sphere of working about von Willebrand disease, and we're always trying to bring new things to our patients and kind of understand things better. And so I'm very optimistic and very hopeful on kind of the next few years in this disorder and this disease.
Well, thank you, Dr. Ng. Thank you so much for joining us and sharing your expertise and your compassion for this very nuanced community. We really appreciate you taking the time today.
Yeah, no problem. It was my pleasure. It's something that I'm very passionate about, and I'm always happy to talk about and help people understand a little bit better.
And that is all for episode 34 of the Ask the Expert podcast series. We are going to be back next year in 2020 with another expert interview. We look forward to having another conversation. BloodstreamMedia.com is your one-stop shop for all of Bloodstream Media's podcasts for the bleeding disorder community.
Once on BloodstreamMedia.com, don't forget to follow the links to subscribe to the Bloodstream podcast, Ask the Expert podcast, the Powering Through podcast, and the Bloodline podcast on iTunes, SoundCloud, or wherever you listen to podcasts.
Have an idea for a future episode of Ask the Expert? Have a question that you would like to hear an expert answer?
Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream Media on facebook.com/bloodstreammedia and on Twitter @bloodstreaminfo.
This episode of Ask the Expert was written by Amy Board.
Produced by Patrick James Lynch.
Rob Bradford.
Joshua Sterling Bragg.
Avra Friedman.
And Colby Crow.
Artwork by Katie Wright-Mead
and Ryan Gielen.
And the Ask the Expert podcast is edited by Allison Stoney.
I'm your host, Amy Board, and until next time, embrace that mystery and fear of life. You are not alone.